We'd like to spend a little time talking with you today about stigma and self-disclosure from a peer's perspective. Having been cautioned about the dangers of reading from your slides in a PowerPoint presentation, we decided to jettison that, but fear not, you'll receive one with all of the academic information about peer disclosures and all the good stuff. But we've decided, in lieu of a more conventional approach, to kind of take a meta-analysis and look at our experience of stigma and how we've experienced it and how we've experienced disclosure in our role as a peer support specialist professionally and also privately. And if you noticed already, there's been a significant amount of disclosure just by virtue of us talking about being peer support specialists, because a peer support specialist is a peer support specialist by virtue of having lived experience. So straight off the bat, very little said, there we are. Hopefully this discussion will inspire some thought as to how the question of disclosure and the issue of stigma behind it can shape the problems around the provision of effective integrated care. And perhaps this may point to ways in which peer support might serve as an effective resource in supporting that worthy task. So with that said, I'll turn things over to Jonathan. Thank you. Jonathan.
Thanks, Grady. So I prepared a personal statement just with respect to self-disclosure, and I'm just gonna kind of jump right into the self-disclosure as well with that being said. So while reflecting on the topic of self-disclosure, I feel strongly that it is vital for me to share some of my own personal experiences. And in this respect, I need to tell you that for the last couple of years, I've been interested in finding a romantic partner. In light of my search while dating, I've been challenged by the dynamic of self-disclosure and the prevalence of stigma. For example, inevitably, people curiously inquire, "What do you do for work?" And often I begin with a general blanket statement about how I work in the mental health field. Inevitably, though, they want to know more, and they ask, "Are you a psychologist or maybe a social worker?" So then I tell them, "No, I'm a peer support specialist," to which the common reply is, "What's that?" So then comes my dilemma. There seems to be no real way of disclosing my role as a peer support specialist without acknowledging in some way my own personal experience in recovery. "What do you mean in recovery?" they ask. To which I reply that I have had my own personal challenges with mental health and that I utilize this experience to try to help others. Though there have been a few individuals that have been supportive, many times interest often fades away. With all this stated, I'm inclined to believe that I have a tendency to disclose too much information too quickly and perhaps end up scaring away a potential match. Regarding self-disclosure, I have found that I need to be particularly sensitive to both the timing and the nuance of words that I choose to use. If I communicate details regarding my diagnosis or my lived experience, often the door of communication just gets shut. So why do I bring this up? All of the peers and FIRST I work with long to have better social relationships. And most of the peers that I work with in FIRST also have aspirations for finding romance. Stigma is one of the powerful barriers that restrains us from successfully achieving these goals. For a percentage of us, the deterioration of our mental health may have impaired what otherwise would have been our effective social functioning. This impairment may have isolated or inhibited us so much so that it has been years since we were romantically or sometimes even socially involved with others. While certainly my role as a peer support specialist is not to play matchmaker, my peers and I do have discussions regarding our relationships. Developing our interpersonal skills is a vital component to our continued happiness. At times, the cultural stigma surrounding mental health diagnosis takes on such a powerful force that it becomes difficult not to internalize the negative misconceptions of society. For example, I begin to think that I'm not lovable, that I'm too disabled or socially inept, or too regressed vocationally to live the life I dream of. Sadly, these insecurities have occasionally been reinforced when I've taken the risk to self-disclose. With respect to seeking romance, I have heard discouraging comments from women stating, "What would our children be like? I don't want to have crazy kids." Or, "You're not going to harm my son, are you?" Or, "I don't think I can see myself taking care of you if you were to have another breakdown." Particularly the comment about children is a difficult one because there is evidence that suggests that my condition is hereditary, and it is difficult to refute whether I would pass on the genetic components. Coupled with both cultural and internalized stigma is also the challenge of integrating the experiences preceding or during psychotic episodes with the positive sense of self. In a forum such as this, it would be unwise for me to disclose some of the details of my behavior precipitating my break and the particular thoughts I experienced while psychotic. Needless to say, some of these experiences continue to haunt my day-to-day confidence when interacting with others socially or professionally, let alone dating. About 2 years ago, I had the opportunity to disclose elements of my personal recovery journey to the ECHO community for the first time. During our preparation, I was asked as to whether I felt comfortable having a recording of my self-disclosure posted on YouTube. After about a week of prayer, reflection, and deliberation with family and friends, I ultimately decided to have the video posted. Though it may sound trite, while discerning whether to publicly disclose my condition, I became more familiar with the positive impact Kevin Love's disclosure had made on larger society. Despite the different realities of public perception regarding having a psychotic condition as opposed to an anxiety disorder, I considered how my disclosure might benefit others and have largely decided to be an open book about my recovery. While the decision was made, this is not to say that being transparent about my lived experience is always easy. Recently, I had the opportunity to discuss elements of my recovery journey with the marketing department at Catholic Charities, and I would be lying if I told you that I wasn't again anxious about the implications my disclosure would make to a wider audience. Even today in this presentation, I wonder, am I disclosing too much? While preparing for this presentation, I read different perspectives regarding the decision and impact of self-disclosure. An article published by SAMHSA reported that while society is impacted by celebrity self-disclosures, stigma is most often reduced by the disclosure of someone in your immediate community. For me personally, learning about the experiences of individuals such as John Nash, Daniel Johnston, Ellen Sachs, and Yayoi Kusama have all bolstered my ability to make peace with my diagnosis and better understand my place in society. Yet despite this, I need to remember that one of the first places I felt like I truly belonged was with my peers at a residential treatment facility for individuals with serious mental illness. While it was not formal peer support, in this setting, I made friends with other individuals with lived experience who had similar life challenges. I saw the humanity within them and our like experiences, and it was a great opportunity for me to learn about a variety of mental health topics. And oftentimes it seemed that my peers with lived experience provided just as much of benefit as the therapists and doctors. This benefit was provided to me because of their courage to self-disclose their experiences. With respect to the opportunity to discuss this topic in an environment of integrated care, I think it is vital for doctors and clinicians to consider the broader implications a diagnosis imposes upon an individual. While the diagnosis is personal health information, the assignment of a diagnostic label such as schizophrenia or bipolar disorder ultimately signifies an entirely different reality to the individual and to society than to mental health professionals. While the use of psychiatric terms within a clinical setting serves as a means of communication amongst a niche of professionals, a diagnosis takes on an entirely different significance when exposed to public opinion or personal internalization. Digesting a diagnosis in both a public or private sphere requires significant personal courage. As an individual with lived experience, one challenge I face is how to effectively dismantle the cultural stigma surrounding our mental health. Do we strive to eradicate language we find to be limiting or offensive? Or do we work with the existing terms and strive to educate the public on the prevalent misconceptions? In my personal experience, my diagnosis has been changed several times over the course of treatment. One of the diagnoses that I received while hospitalized for psychosis was paranoid schizophrenia. When I first read the hospital discharge papers with those words, it resulted in creating an intense anxiety and panic. The word schizophrenia, particularly as it relates to the self, is a scary one, as is the label of being known as psychotic, which was also thrown at me in the course of treatment. This emotional turmoil to these terms continued with me for months after the initial diagnosis. After doing my best to become educated on what schizophrenia and psychosis actually are, I have become a little bit more settled about the labels. Despite this, the general public still seems to think that there is a potential threat to their safety when I raise these terms. Perhaps this is why I have certain apprehension when mentioning these diagnoses in a public setting. While I feel strongly that I have made much progress in coming to accept my diagnoses and their resultant treatment, unfortunately, I still struggle with a certain sense of being apart from others. Hopefully this is a measure simply of self-focus, which will ultimately be overcome through continued progress in recovery. Despite my efforts to find the romance I hope to have one day, I have yet to be successful in this endeavor, but there's still hope. And nevertheless, I am blessed with many friends and supports that have encouraged my growth. Though I sometimes witness the ugliness of stigma made by my decision to self-disclose, I am not ashamed of my diagnoses, whatever they happen to be that day. Despite the cultural prejudice surrounding mental health, I am confident that those with a lived experience have unique and powerful gifts to offer society. Hopefully, through the appropriate use of self-disclosure, we can continue to dismantle the barrier of stigma and lead the lives we dream to live. Thank you. And without further ado, I give you Grady.
Thank you, Jonathan. In 1999, I was at the University of Pittsburgh in my senior year. I was set probably for graduate school in Yale. I was president of the Honors College, yada, 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 promising career. I fell into a psychotic depressive state. I was in a fetal position in my room, not attending any classes, completely dropped out of social activity. One individual, a professor, noticed something and said, you need to either go to Western Psychiatric or you need to smoke a blunt. That was the extent of enlightened psychiatric, care there among the, faculty, the student body, very, very liberal institution. So I did neither of those things. Things got worse. I ended up retreating back to Magnolia, Ohio, small town, I tried to escape from, and I attempted suicide. My family didn't recognize anything. They asked for meds from a primary care physician, no consultation with a psychiatrist, a counselor, anything like that, just because they didn't understand. They didn't want to, on some level, accept that there was a psychiatric problem. Stigma almost killed me. That's a reality in Magnolia, Ohio. I mean, this is 1999. That was a reality at the University of Pittsburgh. Disclosure is a very important and powerful tool in overcoming stigma. And what Jonathan has identified with, public figures like John Nash, and, we have a litany of these people now. When I was in the social club at Coleman, I put up a wall of famous individuals who have mental illness and overcome, things. And I had a mirror in the middle so that people could see themselves in that aspect. But I think about words and I take them apart, and I think about disclosure, and I think against closure. And as a peer support specialist, I am a peer support specialist, again, by virtue of my lived experience. My identity is based on my diagnosis, so to speak. When we think of stigma, if you look at the etymology, it's stigmata, a mark, stigma, a mark. You bear that lived experience, you bear that diagnosis, which is essentially pathological. So you're carrying that. Now, I do believe peer support is an exceptionally powerful intervention. And I think that for some people, the concept of the wounded healer, whatever, that's worth it. That's certainly worth it. But I think when we look at the concept of recovery, which has become a very, very important piece all the way from SAMHSA down, it's becoming accepting that aspect of your self as a piece of your identity. And I reflect on this as I go on in my studies in Masters of Social Work at Akron, and I advance at Coleman, and I continue to be a client and a peer support specialist, all of these different vantage points and roles. And I think about how we approach, mental health conditions. When we disclose and we accept this as a part of our identity, and with peer support professionally, we're doing that, and for a good reason. But for our clients, that's one way of approaching it. But this is integrated care, and we're looking at the marriage, of medical care and psychiatric care, to manage these comorbid conditions and this terrible reduction in life expectancy. A medical model. When I first got sick, I was told it's just like diabetes. You can manage your diabetes, So or when I had a manic episode, the notion was your brain just needs to heal. It's like breaking your leg. So is it perhaps better to think of these things in terms that are just like the expectation is, we're dealing with it in the same way that we would deal with that, and we're minimizing this difference, this divide. And I think about this as I move further along, and I'm doing the consulting and everything else, and it's something I think that changes where you are in managing your mental health condition. Like Jonathan said, the disclosure of the people around him at the recovery camp that he was at was very valuable at that point in time. But is there a point where that disclosure is against closure and moving on with your life, where we have too much identification with the pathology? And I find myself, thinking often about that. Where is the closure? And I believe peer support is powerful. And as I think about a career in social work, I often wonder, is the peer support intervention maybe more effective than the social work intervention, because it's a thing more people don't have, and it's powerful. But to bring things around to this particular echo, stigma, I have seen a very, very big problem as a barrier for my clients getting treatment. One client was in an appointment, and the case manager said, he's a schizophrenic, and the client was immediately felt he was being treated differently. I was with a client in the hospital who was severe anxiety, such that he had worked with his insurance company to have me be able to be with him while he was in the hospital. And the doctor was making his rounds, and he brought up the possibility of multiple MS just because his leg was paralyzed, and with no consideration of that. I have seen at the emergency room people with mental health conditions treated differently. So it's a barrier to treatment. And when you're looking at social determinants of care, it's in terms of discrimination in the community and social context, that's obviously a piece there. and cultural competency for providers, and the quality of care. And these are pretty obvious issues, but the question is, what can we do about that? And I think this is where peer support could be helpful, because you're getting a vantage point that, in terms of, you're not getting from providers, no matter how well intentioned, or on either side, or any aspect of this. And so I think that's something going forward that might be useful. And I think one of the biggest problems that I've seen is med coordination across, like, primary care providers and mental health providers. And I've seen some horrible things go down. And I think peer support specialists can be liaisons there, and also in accompanying clients to appointments in certain instances as engagement tools. But there again, there's the problem of, that's, are you identifying with your illness there with these clients, or to what extent can they just be clients? So I don't know how relevant or helpful any of that was, but that's what I have there. So thank you for your time and the work you do.